Morris here in Wilmington. I'll be talking about earlier diagnosis of Turner syndrome and its impact on clinical care outcomes. So as part of my work here, I take care of children who have X and Y chromosome variations. I do that clinically and in research. And I'll be talking about one of them today, which is Turner syndrome. So Turner syndrome has been around for a bit. It was discovered in 1939, 1940, and it happens when a girl is missing one X chromosome. So generally girls have two X chromosomes, boys will have one X and one Y. When one of that is missing, whether fully or completely or partially, that is Turner syndrome. Besides Turner syndrome, there are other variations that can happen. A girl can have one extra one, a boy can have one extra X, one extra Y. All of these things happen sporadically. They're not things that are inherited and happen right from the very beginning at conception and cell division. So the girls are usually born with this condition right from the beginning. It comes with, when the girls are missing one X chromosome, it comes with different comorbidities, which we'll talk about on the next slide. Now, despite this being present from the very beginning, late diagnosis is a big problem here. It has been a long-standing problem for a long time. A lot of kids are diagnosed much, much later, but there is opportunity to do this earlier because it does have clinical implications. When we talk about comprehensive care in Turner syndrome, so there are multiple aspects of it to think about. At the very beginning is having that diagnosis. That extra X that's missing has implications for growth. So a lot of times the girls are short. Most of them have ovarian failure, so would not go through puberty on their own. They need estrogen treatment, and the timing of treatment of that matters. A lot of them have cardiovascular malformations. They have a higher risk of also having cardiovascular problems. Transition to adult care is a key piece where we tend to lose the kids. Loss to follow-up happens during transition. So that's another area that there's a lot of emphasis on. Fertility assessment, like I said, a lot of them have primary ovarian insufficiency. And so we're monitoring that, counseling them about that. Health surveillance throughout their lifespan and their neurocognition and its implications. So intelligence, I would say, is normal in Turner syndrome. They do have some, I would call them vulnerabilities. They can have difficulties with math. They can have difficulties with visual spatial skills. So like reading maps may be difficult for them, but at baseline, intelligence is normal for a lot of these girls. Why does early diagnosis matter? Really, we want to improve the quality of life. All of what we're doing, when I think about both the clinical care that I do and research, the end point is really to improve quality of life, right? For these kids, timely screening and diagnosis and intervention can help with the short stature. A lot of them have that. And there is growth hormone, which is approved for treating this. A lot of them have hearing loss, so I would say they have a higher risk of having hearing loss, both sensorineural and conductive hearing loss. They can have hypothyroidism, celiac disease. We talked about the neurodevelopmental disabilities that can happen. So knowing about this diagnosis can help them at school get accommodations that will help them thrive at school. And then, of course, for fertility, both for their bone health and uterus, and then oocyte harvesting as needed. There are multiple systems that influence care. So that's really the big thing, is timing of diagnosis has been a problem for a long, long time. What are the systems that can help make this happen, where we have earlier diagnosis of Turner syndrome? Clinical care guidelines are available for Turner syndrome. They were last published in 2024. Prior to 2024, the one before that was in 2017. So we have that. There's non-invasive prenatal screening. Now, it's not true globally, but in the US currently, it is standard of care that pregnant women are offered non-invasive prenatal screening. We want healthcare professionals, whether it's primary care. So if you see a short girl, you kind of really explain why she's short and having difficulty in maths, but doing very well in other subjects and strong verbal skills. Think about that. ENT cardiology, schools, access is a big one. So again, where a child lives matters. It really matters the environment and how much of an impact it has on health. So all of those things are things that can, factors that can influence timing of diagnosis of care. And so my project really was, well, let's start with the clinical care guidelines. We have the guidelines. Let's see, has it made a difference at all? So what I did in this project was to look at temporal changes that were associated with age at diagnosis following the updated guidelines. Like I said, we had the prior to the one in 2024. The last guidelines were in 2017. The question is, has it gotten better with the guidelines, and has it gotten better across board? So when we look at race, ethnicity, insurance, those extra distinct factors, are they making a difference, and how much more? We looked at children with Turner syndrome less than 21 years of age from 2011 to 2023 using PedsNet data. Again, PedsNet is a large health learning system, has 11 currently children's hospitals across the US, millions of data. It's all de-identified. And what I did in this project was break down the cohort into two levels. We had year of diagnosis, so looking at 2011 to 2017, and then 2018 to 2023. So using that cutoff at the 2017 guidelines to see, was there a difference in timing of diagnosis? Our goal really is to bring this down. And then we also broke it down to prenatal and infancy, given that we know prenatal screening is increasing. So less than age 1, and then 1 to 12, and then greater than 12. Greater than 12 is late diagnosis. By then, we have a shorter window to intervene for growth and pubertal induction at that time. So 3 categories to see how these changes have evolved over time. The good news is things are getting better. The median age from 2011 to 2017, median age of diagnosis went from 8.75 to the later period, it went to 6.72, and that was statistically significant. And then when we looked at the diagnosis by age group, so looking at the green is the earlier period, 2011 to 2017, and then red is 2018 to 2023. So you can see those who were diagnosed less than age 1 were about 19%, and that increased to a little over 30%, which is good in the later period. For those who were diagnosed between age 1 and 12, that went down. That's the right direction. That's what we're looking for, so that more people are going in the first bucket. So that went down from about 47% to about 40. And then the late diagnosis, this is the main group that's we're really trying to work on and decrease those who were diagnosed after age 12. That also went down from about 33% to about 28%. So things are getting better. There is still work to do. I mean, 28% is still about a quarter of kids who have Turner syndrome who were diagnosed after age 12. Meanwhile, they've had this all along from the very beginning. And so the next steps really on this project is to examine association of neighborhood factors to timing of diagnosis and care outcomes. Like I said, where a child lives really matters, and looking at how that contributes to timing of diagnosis, and then to harmonize all of this data across multiple domains. So genetics, does it matter what their karyotype is? Family characteristics, income, socioeconomic status, environmental exposures, where they live, and then, of course, clinical outcomes, tying all of that together. Interestingly, one surprising finding from this work, I did not present into results here, but we did see progress across board. So race, ethnicity, all of that. Even in insurance, I thought there would be a difference between public versus private insurance and timing of diagnosis, but that we didn't actually see that. It was about the same for both public and private insurance. The differences came up when it actually, when we started to look at clinical care. So diagnosis is one, and then the care that they receive is another level, and differences show up at that level. I want to thank DE-INBRE who funded this project, PedsNet, my mentors, research team. I couldn't do this without all of them. And then, of course, the families that I take care of in the Extraordinary Kids Clinic. Thank you.